So let's move into case 3. This is a 72-year-old gentleman who started ADT and 6 cycles of docetaxel for metastatic disease. He was a Gleason 8 with a PSA of 40 at the time, had multiple bone metastases. He had a nadir PSA that was actually pretty good at 0.1 nanograms per milliliter, and his testosterone was at a castrate level at 39 at that time, but continued on follow-up PSA testing. That initial treatment was in February of 2015, and follow-ups between June and August showed that his PSA was gradually rising, 0.4 in June, 1.6 in July, and then in August it was 33 with a testosterone of 43. So still castrate, but actually quite an increase in his PSA. His imaging at that time showed a new bone lesion, and importantly, he was still an ECOG of 0, so asymptomatic, really doing well. At that time, because he had already had docetaxel in the metastatic hormone-sensitive or castrate-sensitive setting, he was started on abiraterone and prednisone. Really important, actually, just to remind everybody, as we all know and we all think about, changing mechanism of action is going to be critical, I think, in our patient population to get the best outcomes. Nadir PSA at that time was 0.6. After about 6 months, he was having some fatigue and some belly pain. His PSA had gone up to 5 at that point, and imaging showed 1 new bone lesion at that point. Performance status still good with a PS of 1. And so I think this is our classic patient. He's gotten metastatic castrate-sensitive treatment, docetaxel. First-line treatment of mCRPC was then abiraterone, switching that mechanism. Now he's progressing again. It seems like bone-only progression.